Welcome back to another deep dive. Today, we're plunging into a topic that affects countless lives, but is still, widely misunderstood: Polycystic Ovary Syndrome, or PCOS.
Hmm.
It's actually the most common hormonal disorder affecting women, and people assign female at birth in their reproductive years, so it's really vital we cut through the noise and understand it.
Absolutely. And our mission today is, well, to deliver a clear, comprehensive, but still engaging deep dive into PCOS. We've sifted through the research, pulled out those crucial bits of knowledge, those surprising insights. Basically, we want to help you get genuinely well-informed without feeling totally swamped.
Yeah.
Think of it like your shortcut to understanding a really, really complex condition.
Okay, sounds good. So let's unpack this, maybe starting with a common misstep right in the name itself: polycystic.
Right.
A lot of people hear that and they immediately think, okay, having lots of ovarian cysts is like the main thing. But our deep dive shows a different story, doesn't it?
It really does. Yeah. What's truly fascinating and often overlooked is that despite its name, PCOS isn't just about the ovaries, or even the cysts, really. I mean, sure, some individuals with PCOS do have what look like many small follicles on their ovaries, but those aren't actually necessary anymore for a diagnosis. The real story here, the core issue, is fundamentally a deep-seated communication breakdown. It's in your body's hormonal control center, the hypothalamic-pituitary-ovarian axis. That's what orchestrates your whole menstrual cycle.
Right, so it's a much bigger hormonal picture, a communication problem. Our sources point to these core characteristics. It's a combination of anovulation, basically, not ovulating regularly.
Lack of ovulation.
Clinical or biochemical hyperandrogenism, which is, well, having too many male hormones.
Exactly.
And
Yep.
sometimes the presence of these multiple small follicles that look like cysts on an ultrasound.
And connecting this to the bigger picture, it's really crucial to add that a significant number of patients with PCOS also experience metabolic issues, particularly insulin resistance. Yeah, this connection is actually a really, really important piece of the puzzle. It influences so many aspects of the condition.
So moving from that sort of foundational understanding to the practical side, what signs or symptoms might make someone think, maybe this is PCOS? What might you experience?
Well, one of the most common red flags is definitely irregular menstrual cycles.
Okay.
We're talking cycles that are either unusually short, like less than 21 days, or really long, stretching beyond 35 days. Some people might even get secondary amenorrhea.
Which is?
That's when periods stop for 3 or more months in a row after you've already started menstruating.
Got it. And often because of that ovulation issue, infertility becomes a big concern for many, right?
Definitely. That's a primary concern. And beyond the cycle changes, there are the physical signs you mentioned related to excess male hormones, the hyperandrogenism.
Right, which can be quite distressing.
They really can be. We often see hirsutism, that's the gradual appearance, of course, dark hair where you wouldn't typically expect it, like the face, chest, back, abdomen, those androgen-sensitive spots. Then there's acne, often quite persistent, on the face, chest, and back.
And hair loss, too.
Yeah, another sign is androgenic alopecia. It's like male pattern baldness, but it shows up as thinning hair, often starting right at the crown.
Okay. And our sources also mentioned physical signs linked to that insulin resistance you brought up earlier?
Right. Those can include things like an elevated body mass index, BMI over 25. Another key sign is what we call centripetal fat distribution. Right? Basically, fat tends to accumulate more around the abdomen and trunk. You might see a waist circumference over 35 inches.
Okay.
And one very distinct sign is something called acanthosis nigricans.
Right, I've heard of that. It's like dark patches.
Exactly. Brown, kind of velvety plaques that often show up in skin folds of the neck, armpits, groin. Hypertension, high blood pressure can also be linked. And, a little clinical insight here, something that often surprises people is that during a standard physical exam, the pelvic exam itself, it's typically normal in PCOS.
Okay, so if someone has these symptoms, how do doctors actually confirm it's PCOS? It sounds like a careful process.
It is, yeah. It's structured. The very first step, especially if someone comes in with irregular periods or no periods, is ruling out pregnancy.
Makes sense.
So an HCG level check. If it's positive, okay, it's pregnancy.
Yeah.
If it's negative, that's when a healthcare provider might strongly suspect PCOS and move on to more tests.
Right. What kind of tests?
So mainly laboratory tests, ideally done between day 3 and day 5 of a menstrual cycle, if possible. These tests have 2 main jobs. Confirm that biochemical hyperandrogenism, the high androgens in the blood, and also rule out other conditions that could look like PCOS.
Okay.
So we're looking at hormone levels, things like total testosterone. And an important note here, if these levels are super high, like severely elevated,
Yeah.
that could point to something else entirely, maybe an androgen-secreting tumor from the ovary or adrenal gland. So that definitely needs checking.
Wow, okay. Important distinction.
Very important. And we also check other hormones to rule out different causes of, ovulatory problems. Like there's a specific marker for a condition called non-classical congenital adrenal hyperplasia. We also look at thyroid-stimulating hormone, TSH, and prolactin levels, because thyroid issues or high prolactin can also mess with your cycle.
Got it. And ovulation itself.
Yeah, to check that, we might look at the ratio of LH, luteinizing hormone, to FSH, follicle-stimulating hormone. LH can often be a bit high in PCOS compared to FSH. And a low progesterone level tested around day 20 or 21 of the cycle.
Yeah.
That strongly suggests ovulation isn't happening.
So labs are key. What about imaging? You mentioned ultrasound earlier.
Exactly. Pelvic ultrasound plays a significant role, too. It can show what's called polycystic ovarian morphology.
Which looks like...
Well, the ovaries might look a bit enlarged, or they might show lots of these small, immature follicles. Those are the things often mistaken for cysts. They're tiny, usually just 2 to 9 millimeters. And you wouldn't expect to see a big dominant follicle or a true cyst if it meets these criteria.
Okay.
And here's something kind of interesting about ultrasound. The exact criteria for diagnosing that polycystic morphology, it can actually vary a little.
Oh.
Yeah, depending on how good the ultrasound machine is, basically its resolution. Some guidelines might say 12 or more follicles, others say 20 or more. It can cause a bit of confusion sometimes, but the general idea is looking for that specific pattern.
I see. And you might also see a thickened uterine lining, the endometrium, on the ultrasound.
Yes, exactly. That happens because when you're not ovulating, you get this prolonged exposure to estrogen without the balancing effect of progesterone.
Yeah.
We call it unopposed estrogen. And that can make the uterine lining grow thicker. And this leads to a really critical point, a high-yield fact, if you will. Patients with PCOS who have chronic anovulation, meaning they don't ovulate regularly for a long time, they're at an increased risk of endometrial cancer.
Wow. Because of that unopposed estrogen.
Precisely. And it's vital to understand just measuring how thick the lining is on ultrasound isn't enough to detect cancer. The way to do that is with an endometrial sampling, a biopsy. It's a serious long-term risk that needs careful attention.
Definitely sounds like it. So, okay, the clinician has the symptoms, the lab results, maybe the ultrasound findings. How do they put it all together to actually say, yes, this is PCOS? What are the criteria?
Right. They use what are called the Rotterdam criteria. They're pretty widely accepted. For a PCOS diagnosis, you need to meet any 2 out of these 3 criteria.
2 out of 3.
2 out of 3. First, evidence of ovulatory dysfunction, so irregular periods or no ovulation. Second, clinical signs like hirsutism or acne or biochemical proof of hyperandrogenism from the labs. And third, seeing that polycystic ovarian morphology on the ultrasound.
Got it. 2 out of those 3.
2 out of 3. But, and this is absolutely crucial, before confirming PCOS, other potential causes for the patient's specific signs and symptoms have to be ruled out.
Like what?
Well, for example, if there's abnormal bleeding, you need to make sure it's not a genital infection. If there's acne, could it be from a medication they're taking? Even something like facial hair, could it just be a family trait, genetic, and not actually pathological PCOS?
Right. Context matters.
Absolutely.
Yeah.
So if someone has fewer than 2 of those Rotterdam criteria, or if there's another likely explanation, then doctors will definitely look for other diagnoses.
Okay, that makes sense. It's a process of exclusion, too.
Exactly. Now, if we really want to understand PCOS, we kind of have to look under the hood, right?
Yeah.
Explore why it's happening.
The pathophysiology.
Precisely. And that means understanding a normal menstrual cycle first, and then seeing where things go, well, sideways in PCOS.
Okay, quick recap of normal.
Sure. So normally, your brain's hypothalamus sends out a signal, GnRH. That tells the pituitary gland to release 2 key hormones, LH, luteinizing hormone, and FSH, follicle-stimulating hormone, usually in roughly equal amounts.
Right.
These guys act on the ovarian follicles, those little sacs with the eggs, helping them grow and develop. One follicle usually becomes dominant, starts making estrogen. Then later, there's this massive surge of LH, and that's what triggers ovulation, releasing the egg.
Okay, the normal picture. So where does PCOS mess things up?
Yeah, here's the key breakdown. Instead of that balance, the pituitary gland in PCOS often makes too much LH. sometimes even double the amount of FSH. It's like the volume knob for LH is turned way up.
Ah, okay. Too much LH.
Exactly.
Yeah.
And that excessive LH, it causes specific cells in the ovary, the ECA cells, to overproduce an androgen called androstenedione.
The male hormone precursor.
Right. They make way more than the other ovarian cells, the granulosa cells, can convert into estrogen. So this extra androstenedione spills out into the bloodstream. And some of it gets converted into a different type of estrogen called estrogen by fat tissue elsewhere in the body.
Okay.
Now, this estrogen acts as a negative feedback signal. It goes back to the pituitary and basically tells it, hey, stop releasing FSH.
So now you've got high LH, but low FSH.
Precisely. And because FSH is low, that dominant follicle doesn't mature properly. And because LH is already high, you don't get that critical surge needed to trigger ovulation.
So the egg doesn't get released.
Exactly. The follicle just kind of stalls.
Yeah.
It might stick around as one of those small cysts or just degenerate. The bottom line is ovulation doesn't happen, or it happens very irregularly. And that leads straight back to the irregular periods and infertility we talked about.
Wow.
Yeah.
Okay. That connects the dots. And what about the insulin resistance link? You said that was really important. How does that fit into this hormonal picture?
Yeah, this is where it gets really fascinating. While we don't fully understand exactly what kicks off the high LH initially, the vast majority of people with PCOS also have insulin resistance.
Yeah.
And there's strong evidence suggesting it plays a big role in messing up that cycle.
How so?
Well, insulin resistance means your body's cells, especially in your liver, fat, and muscles, they don't respond properly to insulin anymore. So glucose, sugar, has trouble getting out of your bloodstream and into the cells for energy.
Right.
Your pancreas tries to compensate by pumping out more and more insulin. This leads to high insulin levels in the blood, something called hyperinsulinemia.
Okay.
Now, here's a crucial link. Those ovarian, the HECA cells, the ones making the androgen, they actually have receptors for insulin.
Ah.
So when there's all this excess insulin floating around, it binds to those HECA cells. This seems to stimulate them to grow and divide and maybe even develop more receptors for LH. Some theories suggest this might even cause the hypothalamus to speed up its GnRH pulses, which would further tell the pituitary to make even more LH. It becomes this sort of vicious cycle.
Wow. So the insulin resistance can actually worsen the hormonal imbalance.
It appears so, yes. It's a complex interplay.
And when you look at it that way, you can really see how the underlying issues cause the symptoms. The high androstenedione causes the hirsutism, the hair loss, the acne.
Exactly.
The lack of ovulation causes the irregular periods, the infertility. And insulin resistance itself contributes to the weight gain, the abdominal fat, those acanthosis nigricans patches. It all starts to click together.
It really does. Understanding the why helps make sense of the what's.
Okay, so once PCOS is diagnosed, what happens next? It's not just about managing those core symptoms, right? There's more to consider.
Absolutely. The next steps involve looking at the whole picture. Comprehensive screening for conditions that are commonly associated with PCOS is really important.
Like what?
Things like dyslipidemia, that's abnormal cholesterol, or triglycerides. Also, screening for insulin resistance itself, or even type 2 diabetes, and metabolic syndrome.
How do they screen for those?
Typically involves blood tests, like a fasting glucose level, sometimes followed by a 2-hour glucose tolerance test after drinking a sugary drink. We also assess cardiovascular risk, looking at BMI, getting a fasting lipid panel, checking for all the factors that define metabolic syndrome.
And our sources mention other potential links too, things like sleep apnea.
Yes, obstructive sleep apnea is more common in PCOS. So is heart disease long-term. Mood disorders like anxiety and depression are also frequently associated. And as we discussed, that increased risk of endometrial cancer due to the anovulation.
So it's really a condition with potentially wide-ranging health implications.
It absolutely is, which is why management is so key. And a major factor guiding that management approach is whether or not the patient wants to become pregnant.
Right. So let's take that scenario first. If pregnancy is desired.
Okay. The initial steps are often focused on lifestyle. Counseling on diet and exercise is huge. If the person is overweight, even losing just 5 to 10% of their body weight can make a massive difference.
Really? How so?
It can actually lower those androgen levels, sometimes enough to result in spontaneous periods returning, and it definitely improves pregnancy rates. It's quite powerful.
Wow.
Also, if there's pre-existing diabetes or high blood pressure, getting those under optimal control before conception is vital.
Okay. And if lifestyle changes aren't enough for ovulation?
Then ovulation induction is usually recommended. This involves medications to help stimulate egg release. Common first-line options are letrozole, which is actually used off-label for this, or clomiphene citrate. And for patients who also have obesity, sometimes metformin is added to the clomiphene.
Metformin, the diabetes drug.
The same one. It helps with insulin sensitivity and can sometimes improve ovulation response. And here's an important clinical point to keep in mind. PCOS itself carries a higher risk of developing gestational diabetes and hypertensive disorders, like preeclampsia during pregnancy.
Okay.
And this risk can be amplified if the ovulation induction treatment results in a multiple pregnancy, like twins or triplets. Something to be aware of.
Good point. Okay, now, what about the other scenario? If pregnancy is not currently desired?
Right. In that case, the counseling still heavily emphasizes diet and exercise. But the focus shifts more towards long-term cardiovascular health and weight management. These lifestyle changes are still crucial because they can improve menstrual regularity, help reduce hirsutism, and lower those cardiovascular risk factors we talked about.
Makes sense. And for managing the periods and protecting the uterus?
Hormonal contraceptives are usually the main treatment here. Combination low-dose birth control pills are often the first choice.
Why those specifically?
Well, they do a few things. They suppress that high LH production from the pituitary, they reduce the amount of androgens the ovaries make, and they also increase a protein called SHBG, sex hormone-binding globulin.
Okay.
SHBG binds up testosterone in the blood, so increasing it helps lower the amount of free active testosterone. Plus, the progestin component in the pills protects the uterine lining, reducing that endometrial cancer risk.
Gotcha. Are there alternatives to pills?
Yes. Progestin-containing intrauterine devices, IUDs, are also a good option for endometrial protection and managing bleeding, though they don't help as much with the androgen symptoms like hirsutism or acne.
Okay.
Now, a really important safety point about combined oral contraceptives, the ones with estrogen. They carry a small but definite risk of blood clots, thromboembolism.
Right.
So they should absolutely not be recommended if someone is over 35 and has other risk factors like high blood pressure, or if they actively smoke, or if they have a personal or strong family history of blood clots. That's a critical safety check.
Definitely good to know. What about managing the hirsutism specifically if pregnancy isn't the goal?
Yeah, hirsutism can be really tough.
Yeah.
Honestly, mechanical hair removal methods, shaving, waxing, electrolysis, laser hair removal are often considered first line.
Why is that?
Partly because the results from medical treatments alone can sometimes be a bit, disappointing or take a long time. But medical options do exist.
Such as?
Combined birth control pills can help, as we mentioned, because they lower androgens. Sometimes they're used along with spironolactone.
What's spironolactone?
It's actually a type of diuretic, a water pill, but it also works as an androgen receptor antagonist. It blocks the effect of male hormones on tissues.
Okay.
There's also a topical cream, eflornithine, that can be used for facial hirsutism.
Yeah.
About a third of people see good results with it. Often the best approach is actually combining methods, maybe laser plus medication, to get better results and help prevent recurrence.
I see.
And a critical point about spironolactone, specifically, it is teratogenic.
Meaning it can cause birth defects.
Yes. So if someone is using spironolactone, they absolutely must be using a reliable form of contraception. That's non-negotiable.
Understood. Very important. And finally, what about managing those other associated conditions, the dyslipidemia, insulin resistance, diabetes risk, metabolic syndrome?
Right. For those, insulin sensitizing agents are key. Metformin is usually the first-line choice here as well. It helps improve how the body uses insulin.
And if metformin isn't tolerated, some people get side effects.
That's true. If metformin causes too many issues, like stomach upset, then myo-inositol is sometimes considered as an alternative. It's a type of supplement that has shown some promise in improving insulin sensitivity in PCOS.
Okay, good to have options. So let's try to quickly recap this deep dive. PCOS. It's diagnosed when you meet 2 out of the 3 Rotterdam criteria.
That's right. Ovulatory dysfunction, signs or lab results of hyperandrogenism, or polycystic ovarian morphology on ultrasound.
And crucially, after other conditions have been ruled out.
Exactly. Rule out the lookalikes first.
And then the management is really personalized. It depends heavily on whether pregnancy is desired, and it targets the specific symptoms and health risks each person is facing: irregular periods, infertility, hirsutism, insulin resistance, long-term heart health, uterine protection.
You got it. It's about tailoring the approach.
This deep dive really underscores how interconnected everything is in PCOS. The hormones, the metabolism, lifestyle factors.
It really does. And considering all that complexity, it leaves us with maybe a final thought or question to ponder.
Oh.
Yeah, given this interconnectedness, how might a more integrated, truly patient-centered approach to care that goes beyond just ticking off symptoms and really looks at the whole person, their long-term well-being, their quality of life. How might that further improve outcomes for people living with PCOS?
That's a really powerful question, moving beyond just symptom management to a more holistic view.
Exactly. Something to think about.
Well, that is a great place to wrap up. Thank you so much for joining us on this deep dive into polycystic ovary syndrome. We really hope you feel much more informed now about this incredibly common and important condition.
Hope it was helpful.
Keep exploring, stay curious, and we'll see you next time for another deep dive.